couples have to decide whether or not they are going to become parents. And there are some couples who decide never to have children. Have y'all had those who've had Ms. Zimmerman? Mm-hmm. No, they will never have children, and that's okay. There's nothing wrong with that. She would not be qualified as a good mother. So
I think y'all should show the real life version.
the real life version.
That's not the real life version.
I know. Yeah, exactly. Yeah, those of us who have had children know that there are definitely moments when they're not that sweet, innocent, beautiful little child. And I will be showing you other videos and clips as we go along. The more realistic type of times. But this is when they have to decide whether or not they are going to have children. So it's that transition to parenthood at this stage in life. It's a major adjustment in a couple's life. Johnson & Johnson makes a lot of different commercials, and they have those series where they end saying having a baby changes everything. Have y'all seen those commercials? Having a baby, I think it's Johnson & Johnson, or Pampers, one of those commercials. And that is the honest truth. If you've ever had children, it does change everything. It changes your lifestyle. It changes your money situation. It changes everything in your life. So it does change everything. And parents have to learn how to adjust to this change in order to be successful and to meet the growing needs of the family. And as Joey said, sometimes it's not always that easy. Sometimes it's not all happy-go-lucky and stars and balloons and all that stuff. This is the 8-stage family life cycle, and you've probably seen this before. This one, we are in stage 2, the birth of the first child, new role as parents, integrating new family member into the existing family. Okay, so that's what we're focusing on in this. We're not focusing on anything else except for stage 2. So now we have decided, we're the new family, we're the couple, we've decided that we are going to have children. So the first thing that a lot of people have to do is to go and have preconception counseling. So preconception counseling is, do we want to have children? Now that may not be a formal type of counseling, it may be just together, they decide they have to sit down. And a lot of people don't talk about that before they get married. They don't decide whether or not they want to have children, and then we have issues later on, of course. But they have to decide whether or not they want to become parents first. And what is their goal for the future? Statistics are showing that more people are waiting until their 30s and 40s to have children. And why is that? Careers, school, finances.
They want to enjoy life.
They want to enjoy life first before their life ends. Okay. And they also have to decide, do they want to give up their lifestyle? If they're the kind of people who go out every night after work and have a drink with their friends, or they go to parties and all that on the weekend, that's a very big difference. Did anybody ever see the movie The Neighbors? Love that movie, and it is hilarious. But that's part of their problem in the beginning, is that they're trying to decide how to integrate that baby into their lifestyle. We're going to take her to the club with them and all this stuff. And you can't do that. You really can't do that. And are you living in a location that is appropriate for a child? That's something else that you have to decide. Do we live somewhere that has good school districts? Do we live somewhere that is there a lot of traffic? Is there smog or companies or all those things that you really have to think about before you have a child? Are we close to a doctor, a hospital? Okay. And then the next thing is health problems. What kind of health problems might play into having a child, both personally and as a family? Because family members can contribute health problems into having a baby. So let's look at the risk factors for family health problems. This is a very old picture. I always love these old pictures because nobody ever smiles. Have you ever noticed that? At this time period, they all look so grim. But I guess life was grim. So age definitely is a risk factor, both the very young and the very old. Okay? We associate a lot of health problems with pregnancy with women who are above the age of 40, but you've got to remember that those teenagers that are also getting pregnant and having children are also at risk for a lot of things, and we're going to look at those later on. Child rearing and childbearing can cause fatigue and stress on the body. Okay. Hereditary problems. Is there any hereditary problems in the family? And when you go for your first visit with OBGYN, that's one thing that they're going to ask is, what problems do you have in your family? Are there any genetic problems? Okay. Is anybody born with any disease processes? Does anybody have diabetes in your family? Does anybody have heart problems in your family? Because all those can play into not only the pregnancy, but later on after the birth as well. Okay, we're going to look at that with our genograms. And then lifestyle factors. What lifestyle are you currently leading? Smokers. Okay, it's not a good idea to have a baby if you're a smoker, because of course that's going to cause a lot of problems during the pregnancy, and children of parents who smoke have a lot of health problems themselves. Dental problems, exercise, stress management, all these things can contribute to family health problems, risk family health problems. Okay, so one thing that I'm going to have you do at home is a genogram. Okay? Now, you're going to be responsible for turning this in or bringing it to class on Monday. So you've got a couple of days to work on it. You can make it as fancy as you want to. I've had some that have scrapbooked their genograms and brought in a big old scrapbook page. If you've got a large family, you may have to put it on a piece of poster board. And I'm going to bring in some examples at our next break so you can see what they look like. But you are going to do a genogram. Now, it may take you investigating your family some. Okay? A genogram is a way of mapping out your family to discover if there are any health problems in your family that may be a problem during conception. I'm going to show you mine. So this is not like the family tree. This is not like Ancestry.com. Okay? Open Blackboard up again, and I'm going to show you what mine looks like. Okay. Did everybody see that you start? Now, I just want you to start your genogram with your grandparents. If you want to go back to your great-grandparents, that's fine. But I really just want you to start it with your grandparents, because that really is all that contributes. When you start going back generations and generations, things genetically, it gets less and less of a chance that you can contribute something to your children. But grandparents, parents, you, aunts and uncles, those kinds of things. Now, every year I've had people who have been adopted and don't know their real family. That's fine. Do what you can. If you are not close to your maybe you don't know who your father was, do the best you can do. Okay? Do the best you can do with what you got. And I'm going to show you what mine kind of looks like so you can get an idea. Under Unit 1, you should have about the genogram. You see? Okay. There's mine. Okay. There's instructions on here. So you need to print out your instructions so you'll get an idea of what you do. Now, here's mine. Typically, circles are for females, squares are for males. Okay? So you see, I started with my grandparents. This is my father's parents. You put their birth date and their death date Now, one thing I don't have on mine that I wrote in on my hard copy is their health problems, because that's what this is for, okay? So I've got their birth date and their death date, and then you want to write in any problems that they had. For example, my maternal grandfather had lung cancer. Okay, so that was a big issue that's what he died from, was lung cancer. Okay, so I would put that in my genogram. My grandmother, my maternal grandmother, had she had a lot of heart history, angina. Okay. This is going to give you an example of how things go down in the pipeline. My paternal grandfather died of a heart attack. My grandmother came home one day and found him dead on the bed. Now, we don't know what caused that. It was 1981. I was 6, so I was young. But it probably was similar to what caused my dad to die. My dad died in 2012. He died of a blood clot, a pulmonary embolism. Now, more than likely, my grandfather probably had the same thing. We don't know. They didn't test. They didn't determine whether or not that heart attack was a clot. But what happened is, I don't know if I've told y'all this yet or not, but what happened after my grandfather died, they tested me and my brother, and I have a clotting factor problem. It's a miracle that all these years on birth control I have not run blood clot. But now that we know that I have it, I'm being treated for it. Now, if we had not ever known that, if my dad had not died of a pulmonary embolism, we may never have known that. And I may have gotten on an airplane one day and thrown a clot, and that would have been it. Luckily, now we know that. But you see how things go down in the... Okay, you see how things have gone down in the genetics? It's also good that I didn't throw a blood clot during pregnancy. That was a very risky thing. If we'd known that beforehand, we probably would have done something a little bit different. So, do you see how things have gone down? Do you see why that would have been important? It would have been nice for us to know that while I was pregnant. But it would have been, but we of course didn't know that. Now, another thing I want to show you is that I am not close to my dad's side of the family. In fact, since my dad's died, I haven't seen them at all. We're not close to that side of the family. I have no knowledge of any of their history. I know my cousins, and they've gotten married, but I don't know the names of their children or anything. We're just not close to that side of the family, so I don't know anything about their health history or anything. I've got them on there, though, so that you can see them. But if you've got a situation like that, and you just don't feel comfortable in investigating that side of the family, it's okay. But, just kind of map them on there the best you can do. Okay? Do everybody see that? Obviously, I'm much more close to this side of the family, my mom's side of the family. Okay, and my brother and sister-in-law have since had another baby, too, that I could put on there. Charlie is deaf. My niece is deaf. My nephew's not, but that puts them at risk for having another child that has hearing loss. So, there you go. Does everybody see how that works? So the biggest thing, we're not playing Ancestry.com. The biggest thing is to map out your health problems. And it is interesting, and I want you to talk to your parents, talk to your grandparents. I really want you to investigate this. It is every year, I have somebody who comes and says, this has been so eye-opening for me, because now I can see, back in my family how far the hypertension goes back, or the diabetes goes back, or the heart disease goes back, and you can kind of see what you're up against later on in life. I know it's kind of scary. Well, so that's your project for the next couple of days. Okay, is to work on a genogram. And then we're going to talk about them on Monday. You're going to bring them, and we're going to talk about them as a group. I have had some very interesting genograms. I had one a couple of years ago where she was from New York, and they were from, her family was from somewhere. I cannot even remember where they were from now. But her family believes, without a shadow of a doubt, that her grandfather died from a hex. That he had a hex put on him because he did not marry the woman that his family wanted her to marry. And that they said that they put a hex on him. And because he just died very suddenly, and so she wrote in on her genogram that he died of a hex. I don't know. I mean, you don't know those things. But interesting things. So I want the more you can dig up, the better.
What are the little slashes?
The slashes are divorce. And you know what? That also, don't you think that would affect?
Stress.
Yeah, stress, finances. My uncle has had no luck with marriage. He's divorced twice and is on his third girlfriend. Yeah, has 3 kids. So, yeah, the slashes are divorce. Okay, does everybody understand what to do? Okay, now you need to color code it as well. Shh. You need to color code it as well. So you want to try to make things like if you want to do the men in blue, the squares in blue, and the women in red, however you want to do it. You want to make it as pretty as you can. You want to make this interesting because I keep these and I like to show them. So I'm going to bring you some to show, to see that I've got. Maribel Pena. I don't know if y'all know Maribel, she just graduated. She used a piece of poster board, and she really probably could use 2 pieces of poster board because she had like 17 uncles and aunts on one side of the family, and then like, I don't know, ungodly amount of cousins. And she's Hispanic, and I mean, they had a huge family. I mean, it was like massive. So interesting.
So I would include my brother on there, but I included his wife in there.
Yes, if you can. Yeah. See, Adam has a sexual history. Okay, so, all right, so the childbearing phase of family development is very personal. Your decision is very personal, but you would be surprised at how many people will answer your sexual history questions, okay? So it's never easy. You make direct eye contact with them. You don't use slang terms, if possible. Okay, you don't write on your sexual history, oh, I see you had the clap. Okay, you don't do that. You try to be as professional as possible. And usually, if you are very straightforward with them, they will tell you exactly what they've done. Now, one thing that you're going to ask is their fertility. Did they have to use fertility drugs to get pregnant? Contraception, okay? Their method of contraception. There are different types of contraception. The first one is what we call BBT, which is basal body temperature. This is just fertility awareness. How aware of you for your cycle, when your cycle occurs. Now, this is considered natural family planning. Natural family planning. So a BBT, a basal body temperature, is when you take your body temperature every morning before you wake up, before the activity. Your temperature rises throughout the day, and it also rises in response to ovulation. So So that's how people know when they are ovulating. Now, it takes a long time. It will take several months of practice to get that right, because not a lot of women are aware of that method. Okay. Now, the rhythm method is very unreliable when you're trying to get pregnant or trying to prevent getting pregnant. The rhythm method is very unreliable. And that's what you have to tell people, especially for who? Well, Catholics, yeah, especially for Catholics. But especially for women who what? Don't have a regular period. They don't have a regular period. It's very difficult to practice the rhythm method. Okay, spermicides. Spermicides destroy the sperm and neutralize the vaginal secretions. Okay. Now, the problem with spermicides is that they have to be applied every time there is sexual activity. Okay, so it has to be kind of planned out. The other problem with spermicides is that they don't last any longer than an hour. So after an hour, you would have to reapply the spermicide. What do you use them in conjunction with? Condoms or a diaphragm. Condoms or a diaphragm. Exactly. Okay. Barriers. That's what we consider your condoms. Did you know that there is a female condom? Everybody knows that they're a female condom. They are 97% effective with correct use. And that is a very important statement there, with correct use. Because a lot of times you'll hear people say, oh, well, I got pregnant and we used a condom. Well, probably they were not using it properly. Or it's a condom that had been in the pocket for a long time or in the wallet for a long time and it was old. And that's why they break, because they do. 86% effective with typical use. That doesn't give us a lot of room there. A diaphragm. The thing about a diaphragm, it has to be fitted by a professional. Does everybody understand that? That a diaphragm is not something you just purchase on your own and hope it works. That it has to be fitted by a professional, and it has to be left in for 6 hours after sex. Has to be left in for 6 hours after sex. Long time.
Now, the NuvaRing considered a diaphragm?
No. It's considered an IUD, type of an IUD, yeah.
But is there one that they do themselves? Is that
The NuvaRing is what you can put in yourself.
you do yourself?
Yeah.
And I'm sure they get put in wrong a lot of times.
And they do get put in the wrong way, yeah. Okay. A cervical cap. You don't see cervical caps much anymore. Shh. A cervical cap also is fit by suction, similar to the diaphragm. It should not be left in for any more than 24 hours. If you leave in a diaphragm or a cervical cap in for greater than 24 hours, you become at risk for toxic shock syndrome. So we definitely, and everybody, especially girls, remembers on the sides of the tampon boxes, you know, they talk about TSS. Same principle, because what would it do? What would a diaphragm or cervical cap do? Now remember, TSS is a bacterial infection, so what is it doing? If it stays in place for 24 hours, what's it going to do?
Start
it
growing.
can trap bacteria. And so what will it do then? If it traps the bacteria there at the cervix, what's it doing? It's going to crawl up into the cervix and cause a really huge inflammatory response. Very, very sick. People with toxic shock syndrome are extremely sick people. Okay? Your IUDs, there's a lot of different IUDs out on the market now. An IUD stands for intrauterine device. Hopefully everybody understands that. They are triggered, they trigger a spermicidal reaction by the body. So when sperm comes in contact with the IUD, it kills the sperm. One of the most common ones now is Mirena. A Mirena IUD. And you've got a picture. On this picture, there's a little Mirena.
Is that the one that's got the plastic ones?
Yes. It's got strings. A Mirena has strings that they cut, and you're supposed to feel for the strings with every period and all that stuff. They only recommend IUDs for women who have had one child. Now, that is becoming less common now. I have had students that have told me that they have had a Mirena and they've never had a child. Or they are monogamous. They will ask you these questions before you get it. The reason for that is because women who have not had a child or are not monogamous are at an increased risk of pelvic infection. So that's why they really don't want to use that method. They're going to try other things first. Okay.
There's a permanent one too, but it's...
There is a permanent one. Do y'all remember the Norplant that used to be? Does anybody have one?
I have an Explanon.
You have the Explanon. Okay. So everybody can come feel Hope's arm later. She has an Explanon. You have the two.
No, it's just one.
You just have the one. Okay. They used to have them where there were several different little plates in there, and now they took them off the market for a very long time. Norplant came off the market.
Hard to go in and retrieve them after that.
Exactly. They couldn't find them. They were at risk for all kinds of problems. So they took them off the market for a long time, and now they've got it where they only have the one little implant. Okay. Hormones like birth control pills, and I wanted to show you this next slide. You know, I like these little mnemonic things. These are some of the ways that you can remember about birth control pills. These are serious complications. And a lot of people don't realize that hormones, such as with birth control pills, can cause so many problems, but they really, really can. Especially if you're like me that has a clotting problem, these put you at really high risk of blood clots. So you've got to be careful. So this little mnemonic is a really good way to remember. It's aches, abdominal pain, chest pain, headaches, eye problems, or severe leg pain. And of course that would be your DVT. So these are some of the severe complications of a birth control pill. What else is a problem with the birth control pill? To remember to take it. And a lot of people don't. That's why a lot of younger people especially, they're trying to steer towards the NuvaRing, the diaphragms, all those, because they forget to take it, or they can't remember at the same time every night. So there are a lot of complications, as you can see, but there's also issues with taking it every night before you go to bed. So there's an extensive history that has to be done with these patients before you actually will put them on it. There is a combined estrogen progestin pill. Some women cannot take estrogen. It just makes them very, very sick. They just cannot tolerate estrogen. So there is a plain progesterone pill that they can take. The pill is highly effective if done properly. If it's taken correctly and if they don't have any of these complications, it's very effective. A lot of women will also be prescribed birth control pills if they have really heavy, painful periods, which we're going to talk about later. The dysmenorrhea, women who have really painful periods, they will actually put on a birth control pill to help to regulate and calm down those periods. They used to have a patch called Ortho-Evra. You remember that? I had those patches. I used those patches for a while, but it's off the market now. We talked about NuvaRing is a ring that women inserted to the vagina. I've had a lot of students who told me they love their NuvaRing. They would swear by their NuvaRing. NuvaRing is a soft, flexible ring. Let me go back and you can see a picture of it. Oh, I have a picture, yeah. There's the NuvaRing. It's a soft, flexible ring. Women will insert it into the vagina. It's left in place for 3 weeks. 3 weeks. And then it's removed for 1 week. And that's to allow for menses. Okay. The other thing that you hear about a lot is Depo-Provera. Depo shot. Anybody get Depo? A couple of you get Depo. Depo suppresses ovulation for 3 months. That's the good thing about Depo. It's given as a single injection. The difficulty with Depo is that women complain of having a problem with a delay in return of its fertility, and it may take up to 9 months to a year to be able to ovulate properly to be able to get pregnant. So if you're wanting to get pregnant immediately, Depo is not the way to go, because it takes a while to get back in shape, to get your body back in shape, okay? That's the problem with Depo. Now let me tell you something else about the diaphragm. Go back to the diaphragm for a second. Diaphragms, if you have someone who uses a diaphragm, they have to be refitted. Remember, that was one of the ones that I said that has to be fitted by a professional. Every time you lose weight, 15 pounds or more, either way, or you get pregnant, a diaphragm has to be refitted. So you may have one diaphragm, but it doesn't last you the whole time. Okay? All right, so you're asking their sexual history, you're asking them what they use. This is another little, and I probably will definitely put these pictures up for you, because here's one about Depo. Talks just a little bit about Depo. It's given IM, 1 injection every 3 months. Okay. All right, let's talk about infertility, and then we'll take a break. Infertility, and I gave you a handout on infertility if you want to pull that out. A lot of people will actually come into the office and talk about the fact that they can't get pregnant. It is a lack, infertility, true infertility, as a lack of conception despite unprotected sex for at least 12 months. So the problem is that they cannot, and I want you to really look at this handout as we're talking about it, because that's what I'm going to really rely on, is this handout. Infertility will not, a couple will not be denoted to be infertile until they have been able to not get pregnant for 12 months. They've had 12 months of unprotected sex without result. So they're not going to do studies, they're not going to do any of these infertility studies until they see that you have been having unprotected sex for 12 months. Unless you're an older couple, because you don't have that much time. You know, if you're 36 years old, then they may only let you go for 6 months without doing the studies. Does that make sense? If you're younger, you've got more time to play with. But if you're older and you've waited to have this child, then they're gonna look into other things quicker. Now, the thing with infertility is that it is not just a female problem. It can be a male problem. And if you look at your handout, it talks about that. That 1/3 of the cases of infertility is women, 1/3 of the cases are men, and the remaining third are caused by a mixture of male and female factors. So it could be a little bit of both. Okay? Now, what causes infertility in men? Okay, it may be that they're not producing enough sperm. And it may be that they're not able to reach the egg to fertilize it. It may be that the shape of the sperm is not appropriate, or they just can't get there. The little swimmers just can't get to the egg. Okay? You see the list of things that can cause infertility listed for you. Injury is not on there. That's something that you always need to think about. Injury, such as sports injuries, can cause problems. Okay. Women who have problems, their risk factors are listed there for you. There's a lot of women's problems is that they have a structural problem with their fallopian tubes or their pelvis, maybe uterine fibroids. It may be that the eggs are not maturing the way that they're supposed to. All right. So the couple comes to the office and they're going to be treated for infertility. The first thing that they're going to do is they're going to look at psychosocial, physical and psychosocial issues. So they're going to talk about, maybe it's not just, and this really can be a problem. Maybe one person wants to get pregnant, but the other one doesn't, and there's a lot of stress in the relationship, and that can be a problem. So they're going to look at that first. The first person that they're actually going to look at is the female. And they're going to investigate her ovulation cycle. So they're going to have them do the basal body temperature. They're going to have them keep a diary. There are ovulation kits over the counter. And your little handout talks about those ovulation kits that they will have to look at to see when are they ovulating, and are they ovulating at a regular rate. A lot of these women, it's just the fact that they are not ovulating at a regular rate. Maybe they have an irregular cycle. Okay? So they're going to look at their ovulation. They may do an ultrasound, a transvaginal ultrasound, to see the structures. Okay? The next thing they're going to do is they're going to look at their cervical mucus. Is their cervical mucus elastic? And I know that sounds odd, but they're going to look at the mucus to see if it's hospitable to the sperm. Okay. They may do a evaluation of the structures. They can use, on your handout it talks about a hysterosalpingography, which is an x-ray to check for the different factors, the different structural factors. And they may go as far as doing a laparoscopy, which is where they make a little incision and go in to evaluate the fallopian tubes, the uterus, looking for scarring. Women who have endometriosis have a lot of scarring built up, and those women have large infertility problems. And then the last thing that they're going to do is they're going to look at the male. They're going to check his sperm count. They're going to see if the sperm are viable. Are they putting out enough, and do they live for a long period of time? Okay. Now, there are different ways to treat infertility. Medication is the first thing that they're going to do, and they've got a list of them there for you. Clomid is one. Clomid is listed there for you. Clomid increases the chance of ovulation in women 70%. 40% of those that take Clomid end in pregnancy. The problem with Clomid is that it increases your risk of multiple gestation, multiple pregnancies, twins, triplets, quads. Okay. There's another one called HMG, or human menopausal gonadotropin. There's two examples there for you, Repronex and Pergonal. Okay. These are for women who have pituitary problems, people who have thyroid issues, like hypothyroidism or hyperthyroidism. A lot of those women have trouble ovulating, and so they have to be on these HMG drugs, human menopausal gonadotropins. And those are injectables. They're given as a shot, and what they do is they help the woman to ovulate. Okay, so there's some others. FSH, follicle stimulating hormone, is listed for you on the back. There's some gonadotropin releasing hormones. Look at metformin. You've seen that in another type of disease process, haven't you? What is that used for? Diabetes, glucophage. Okay. That is for women who have polycystic ovary disease. And we're going to talk about PCOS later on. PCOS, polycystic ovarian disease or syndrome, causes women to have insulin resistance, to make their bodies become inhospitable for sperm. And so they will give them glucophage to decrease their insulin resistance and helps them to ovulate. Okay. Now, if drugs don't work, the next step that they're going to go to is what they call IUI, which is intrauterine insemination. Okay. That is the next step, is IUI. IUI takes sperm from the man, and they deposit it, the physician will deposit it at the cervical os. So it takes away the trip from the outside, from the vagina up the cervical canal. Those are for women whose cervix, their cervical mucus, is inhospitable.
Can you repeat that whole pathway?
Yeah. So IUI takes the sperm, they put it at the cervical os. They bypass the whole trip from the vagina up the cervical canal. For women who have cervical issues. And it may be that they have their cervix is not shaped correctly. Or it may be that they have a cervical mucus problem. So it bypasses that whole trip. That's what, you always hear about people in their turkey basters, which is not true, but it's a similar concept. It's using the man's sperm and the woman's egg. It's using the same thing, but it's just bypassing that whole trip. Okay? If that doesn't work, then they will go, the next step is IVF, what is that? In vitro fertilization, right? In vitro fertilization. In vitro fertilization is where they take the woman's eggs out of the ovaries, they fertilize them with the man's sperm in the lab, and then they put them back into the woman's uterus after normal embryonic development has begun. So that's the second phase of IVF. So you've got medicines first, and then IUI, and then IVF is the last result. Now, a lot of physicians, infertility physicians, will actually implant more than one fertilized embryo because the chance of one of them dying off is great. Then you've got some women who go through IVF, and how many ever embryos they implant, they all grow. And that's where you get all these multiple babies from. Okay.
Ms. Ward, a friend of mine had IVF. She had 3 eggs implanted, but the process of injecting the sperm into the egg actually made it split. So she ended up with a set of identical twins, and then another girl and one on top of that. So she had quads.
She had quads, and one set was identical.
Yeah. but it was
That happened. Yeah, that happened with a couple that I met in NICU. They had triplets. 2 of them were identical. They were all 3 girls. 2 of them were identical, and then they had a third who was not identical. She was left out, bless her heart. But yeah, that does happen, so that is a risk factor. And so when you're teaching people about this, that's something that you need to let them know. Having one baby, having 2 at one time, or 3 at one time, or 4 at one time, those of you who've had twins know. Multiples are hard. Multiples are hard. Okay? All right. There are a lot of other types, and your handout talks about gift. It talks about intracytoplasmic sperm injection. Those are some big terms. Those are some other types that usually we just see IUI and IVF. Okay? These are just some other extreme measures of infertility. Infertility has a lot of psychosocial issues as well. And that's one thing that we really cannot forget is the psychological factor of infertility. Not just for the female, but for the male as well. And not knowing or not being able to produce a child without assistance can be difficult. So we've got to remember to be very sensitive to them as well. It's very, very, very expensive. My brother and sister-in-law ended up having to go through IVF all the way through. They've gone all the way through with 2. Now, they've had 2 children, but there's still 5 embryos in the lab. And Virginia is passing a new law where any embryos that are left over a certain period of time will be used for research or tossed. And so there's a big controversy right now over that, and the fact that, they don't want any more children. They're only going to have 2, but, what to do with those extra embryos. So there's a lot of ethical and legal ramifications to IVF as well. So they're having to decide, what they're doing about all that. So, it's a bigger factor than you think about. Some states are having to go through that right now. So, all right, let's take a break. Another about 15 minutes.
So do they ever, do doctors ever tell patients that they're just trying to abort?
Yes. And a lot of people stress over getting pregnant. I mean, they're really, it's like they just really, really, really stress over it. And they tell them, just relax.
Because we tried for 2 years with my daughter and all that. And then a month after we actively quit.
Stopped, yes, exactly. And a lot of people will give up and they'll start working on adoption for other kids and stuff and magically they get pregnant because they're not thinking about it anymore. They're not stressing over it. Okay, so there's a wide variety up here you can look at. There's one like Megan's who has like 500 different relatives. And then there's some that don't have, many at all. So you need to do what you can. I always hesitate saying that because I don't want you to just not put any effort into it. I don't want you to have like 2 or 3 people in there just because you didn't try. Now, for those of you who can't get in touch with those people or don't know, that's a whole different ballgame. But I just want, these things are very fascinating. They're very interesting to look at. So I've got them up here. You can look at them. You can see how people have done theirs. So be creative as possible. All right. Any questions about the genograms? Okay. Got a couple people testing today. So got my fingers crossed. Whew. All right. Get out your big bad bugs of STDs. We're going to talk about some gross stuff. All right. One of the things that they are that they are going to talk to you about in your appointment is whether or not you've had any STDs. They're also going to want to know if you would like to be tested. Now, some of them they're going to test you for without even asking. They're just going to go ahead and test you. But some of them, like HIV, they will ask you if you are interested in being tested for it. STDs are caused, of course, by infection that's passed from one person to another. It can be different ways. It can be intercourse, intrauterine, and intrauterine means from the mother to the child, to the fetus, or perinatal during delivery. Okay, so it can be passed in the uterus, or it can be passed after delivery. So those are some different ways that it can be passed. The big bad bugs of STDs, I don't, but
There may be one here.
yep, I do. Right here. Okay. All right. The first, what we're going to talk about now is reporting. And you're going to see this when you go to the health department, that a lot of these things have to be reported. Okay? Chlamydia, gonorrhea, syphilis, HIV, and AIDS all have to be reported. Now, I looked up yesterday the number of cases in Rowan and Cabarrus County, and actually they're not too bad. I thought I had my numbers written down, but apparently I didn't save them. Chlamydia, I do know that chlamydia right now is higher in Cabarrus County than Rowan County. In between January and March, I believe, if I'm remembering correctly, there were 226 cases reported in Cabarrus County of chlamydia, and only 100 and some. Now, those numbers I'm not going to test you on, but just to let you know. And then it's opposite for gonorrhea. Gonorrhea is higher in Rowan County than in Cabarrus County. I believe so. They only report January through March of every year.
She said yesterday at the health department that out of the whole state, just for STDs in general, Rowan County has the highest incidence in the entire state.
Isn't that awesome? Isn't that awesome?
So she was telling all the patients that, and so I asked her, I said, did I hear you say that right? She said,
We are happening, County. Isn't that great? The good thing is syphilis, we haven't had any cases. I think Cabarrus had one. I think it was either Cabarrus or Rowan had one case of syphilis and the other one had no. So that's a good thing. And then HIV and AIDS, those numbers are still fairly low, about 8, about 5, 6, 8, somewhere around there. But that's wonderful. I'm so glad to know that. So the prevalence of STDs, of course, is a concern. It is a very big concern, and we're going to look at some of the ones as we go through our big bad bugs. We're going to look to see which ones are the worst as you're pregnant as well. It can lead to a lot of complications during pregnancy, so that's why they want to know before you get pregnant and have a child if you have an STD. Okay, so the first one we're going to talk about is syphilis. So flip to your syphilis bug. And the syphilis bug, I found a picture of 3 little bugs together. I thought he was cute. And I printed these out for you because I wanted them to be in color. That's why I copied them out for you. Wasted all that paper. But so what we're going to talk about, what you really need to know are the 3 different things. Okay, so what is it? How do you get it, and how do you treat it? Okay, so 3 different things there. All right, so let's talk about what syphilis is. And the reason I put 3 little bugs up there is because there are 3 phases to syphilis: primary, secondary, and tertiary syphilis. The problem with syphilis is that it can become systemic, and it can cause very serious complications, even death. So that's why when you're remembering on your test, that's why there's 3 little bugs there, because there's 3 little stages of syphilis. primary syphilis. Nice little picture of penis tip. With syphilis canker. Primary syphilis is characterized by the appearance of a lesion or a canker, what they call a canker. Okay, and you see that lesion right there on the tip of that penis. Those of you who have teenagers, I'll give you permission to show these pictures to them because they need to see it. They need to see these things. Onset is 10 to 90 days post-exposure. So it may take a little bit for it to onset. 10 to 90 days post-exposure. It's highly infectious. This lesion or canker weeps. Okay? It actually will weep and drain. Now the canker will actually disappear within 6 weeks with or without treatment. But the client is still very contagious. And that's why I've got that in big bold letters. All caps. Client is contagious. Okay. So what do you have on your little hands when you're doing their assessment? Gloves. Have your gloves. You might want to double glove. Okay. These are the long gloves that you want to put on, you know, the ones that go up here. So women, even though I just have a picture of a penis up here, women will also have that canker. Okay, and so you're looking on the vagina to see that little canker or that lesion. They may also complain of lymph node enlargement. Okay, lymph node enlargement that may be tender. All right, so remember I said that canker is going to disappear with or without treatment within 6 weeks. All right, secondary syphilis, this is a picture of secondary syphilis, is the onset from 6 weeks to 6 months of a rash that develops on the hands, the feet. It may develop around the mouth if you've had your mouth somewhere it should not have been. Okay. Yes, if your mouth has been somewhere it should not be, then that's why this man has it around his mouth. Okay. You see it on the hands and the feet.
Why the feet?
I don't know. That's just where it develops. Generalized. Yeah. This rash is contagious. So you, again, are not touching it without gloves on your hands. Okay. They will also report symptoms of like a flu-like symptom where they're tired, they have a fever, a headache, muscle aches, and then this rash appears. Okay, so it can onset anywhere from 6 weeks to 6 months after they've been exposed. The rash will typically last 4 to 6 weeks. Now, if you still have not gotten treatment, which we hope and pray that you have at this point, then it will go to tertiary syphilis. There's not a picture for tertiary syphilis because tertiary syphilis is an internal infection. So you really can't see tertiary syphilis. It onsets about a year after exposure, and this is what can cause death. Bless you. Did anybody ever see, bless you, Out of Africa?
Oh, I did. That was a good movie.
If you've never seen Out of Africa, you should see it. It's a very, very good movie. In that movie, though, she has to go home. I don't know. Anybody seen it besides me and Angela? Nobody else has seen it? Nobody else has seen Out of Africa?
I think a long time ago.
It's an old movie. It is an old movie, but it's very good. She moves to Africa.
Great place.
I dreamed of Africa, whatever. She moved to a very good movie. But anyway, in that movie, it was made or it was supposed to be set like in the 20s and 30s, and she ended up having to go home. She and her husband were estranged. She found out her husband had been sleeping around with some tribal women in Africa, and she got sick and developed this rash. And what they were alluding to in that movie is that she actually developed syphilis. And they would send them home to sanitariums to be treated. So if you've ever watched that movie, if you ever do get a chance to watch the movie, it really is a good movie. Anyway, so they have lesions, they have heart problems. Now it's settled into the heart, into the connective tissue. So we have valvular disease, aneurysms, meningitis. They'll talk about syphilitic meningitis, where the lesions that appeared on the outside of the body are now on the brain stem. And eventually it will cause death. So very, very serious. You never want to get to this stage, of course. Never want to get it to begin with, but you don't want to get it. Definitely you don't want it to last to tertiary. Now there is a treatment. It can be cured. It can be treated if you catch it in time. You give them a shot of penicillin. It's called benzene. Whoops. Let me go back. Benzene penicillin G. If I get my arrow up here. Oh, let me just walk over here. Benzene penicillin G. It's an injection. And it only takes one injection. Okay. There is a problem that can occur, however, with patients who get the penicillin that have syphilis. There is a reaction, and it's just for people who have syphilis. They get this shot. It's called Herpes. And what happens is when the penicillin is injected, it reacts to the syphilis cells, the syphilitic cells, and they burst and they release this inflammatory products into the body. And so it causes this huge painful knot at the injection site. There's not anything you can do about it. It's just the way that it reacts to the disease process, except give them Tylenol, localized, ice and stuff. But there's really not anything you can do about that. One thing that you need to make sure that you teach these patients is that everybody has to get treated. Okay? Everybody has to get treated. So I know there's a lot of a knowledge deficit with these patients. This is not one that just the person who has syphilis has to get treated, but everybody that they've been in contact with. Now, when you report it to the health department, again, that's something that we have to report. Excuse me. When they report it, they will actually do some investigation, and they will follow the chain. They will contact that person, and they will follow the chain of their partners. And everybody that partner has been in contact with has to be treated, and so on and so forth. So everybody gets treated because it is highly, highly contagious. And abstinence, you teach them abstinence until the treatment is over, until it's finished. Okay? All right, now find your genital herpes slide. Your genital herpes bug. I think he has some little warty looking things on him.
How was it diagnosed?
Well, it's diagnosed by that canker at first. Okay, genital herpes, little orange bug. Pardon? Yes, you can give it in all stages. Now, if it's gotten to tertiary, though, I will tell you, if it's gotten to the tertiary stage, it's probably not going to be able to be fixed. At that point, because it's settled into the connective tissue, into the heart tissue, we're in big trouble by that point. Okay, genital herpes is, the problem with genital herpes is that there is no cure. Okay? You see a lot of commercials on TV. Do you know how much they probably have to pay those people to get on TV and say, yes, I have genital herpes and I'm being treated with Valtrex or whatever. You know, those people that get on TV. And they always look so happy. Have you ever noticed that? They always look so happy. Right. This is a recurrent viral disease. It recurs in times of stress. Would pregnancy be considered a stress reaction? Yeah. So that's why they really have to watch out for these women who have genital herpes. The latest statistic that I saw is over 50 million people. 50 million people in the United States have genital herpes. And most people that are infected have not been diagnosed. That 50 million is the people who've been diagnosed. That's a lot.
They say something like 1 in 4.
Yeah, 1 in 4 people have. Now, genital herpes is not something that has to be reported. So that's a little bit more concerning because we don't really know. The only statistics we ever know is the ones that are treated for it. Okay, you know there are 2 types. Non-genital lesions are your cold sores, the ones that you get on your mouth. Okay, that is herpes, herpes simplex 1, and there's creams that you can put on that. A lot of people get those. Canker sores, yeah. And then there is genital lesions called herpes simplex virus 2. HSV 2. Okay. Here's a nice picture for you. Okay. Make you wiggle in your chair. The way that people know that they are getting an outbreak is they complain of itching and tingling to the skin prior to outbreak. It's followed by the appearance of vesicles or blisters. Those blisters erupt and then erode. Lesions will resolve in 2 to 6 weeks. But again, the virus remains in your system. So these eruptions, these outbreaks can occur often.
Is it transmitted only during an outbreak or any time?
It can be transmitted anytime, but the higher incidence of transmission is during outbreak. Of course, because you've got those blisters that are open and weeping.
Is that because the skin's shedding?
The skin's shedding the cells. Yeah, it's shedding the virus.
Okay.
Yeah. Okay. Had enough of that picture?
Yeah.
Okay. It goes through periods of dormancy and recurrence, which we talked about that. It resides, it lives on the nerve ganglia. If you remember from anatomy and physiology, it resides, that's where it lives in the meantime, while it's dormant, while it's sleeping, on the nerve ganglia. Something as stressful just as sunburn can cause an outbreak. It can cause cervical cancer. Now we are seeing more of a correlation between HPV, genital warts with cervical cancer, but genital herpes can also cause higher incidences of cervical cancer. It can be transmitted to a newborn, if they're pregnant and they have had an outbreak and they're getting ready to deliver, they will not let them vaginally deliver. Okay? They will let them vaginally deliver if they are not currently having an outbreak. Okay? Because it's no more of a risk than if they were having a C-section. Now, will they still contract the virus? They still could. But it's a lower chance during a section than with vaginal delivery. Okay? It's not controllable, it's not curable, but it is controllable with all those medicines that seem to make people happy on TV. These are the medications that are most common. Zovirax or acyclovir, all of your Virs, famciclovir, valacyclovir, so your Famvir, your Valtrex. So if you see a Vir on the end, you know that those medications are your antivirals for your genital herpes. What they do is they accelerate the healing of those lesions. So those are only taken usually during an outbreak. Now, some people with frequent outbreaks, they will make them take it on a daily basis. So if they tend to outbreak a lot, they'll say, oh, okay, well, you're just going to be on Valtrex all the time. But if they only have an outbreak rarely, then they will just put them on it during the time.
You said they do what now?
It accelerates healing. Yeah.
Will they test a baby if the mother has it?
Oh, yes. Yeah. Yeah. And a lot of times they'll just go ahead and treat them, until the test comes back. The good thing about daily treatment, daily suppressive therapy, is that it reduces outbreaks up to 70%. So it's really a good thing for these patients to be on it all the time. That way they don't have to run the risk of having those open lesions that are being transmitted to the baby.
Can they still take that while pregnant?
Yes, it will cross the placental barrier, so there is a risk for that, but those babies are probably going to need it anyway, so the risk is not going to. So what would you teach these patients? What kind of things would you tell them? Condoms. Abstinence is probably best, but definitely condoms.
No sex when you have an outbreak?
No sex when you have an outbreak. All right. What about sharing personal items like towels and stuff? No, especially not when there's an outbreak. So no sharing towels or other personal items, making sure toilet seats are cleaned or covered. That's why my grandma taught me to squat early on in life when we're out in public. Those of you who have girls need to teach your girls how to squat.
So if you have herpes 1, does it develop the herpes 2?
No. There is a genital type and then the type that just causes the little...
But you take the medication for either one.
Right. Right. Usually, though, there's a cream version of the Zovirax. There's a cream version that you can use for your mouth, but it helps to heal. Okay. What would you do? Gloves, definitely. It's even when applying ointments. Okay. And also teaching them to make sure that when they do have an outbreak, that they keep that area dry as possible, because remember, those blisters are going to erupt and weep, and so making sure that they wash frequently in that area and that they pat dry, and to avoid the breakdown of the skin, because the skin's going to become corroded too. All right, ready for your next picture?
Where are we going?
Gonorrhea.
Yummy.
Is this the one where they would put like, one of my old coaches when I was in high school told me that they had to put a razor blade thing inside of his pecker And then hit the little button, little razors come out, and then they pull. It was either the clap where he had gonorrhea from when he was overseas.
Probably the clap.
Yeah, from somebody. They pulled it out, and then they just smacked it right there. Pus flew everywhere.
That was crabs.
Right, crabs, yeah, it's right,
What they
crabs.
said before they did that, they used to just set it on the table and just hit it with a mallet and stuff square out there.
Yep, that's the clap.
It's sanitary.
I guess he told y'all that to make sure you kept it in your pants, I'm assuming.
No problem.
Wow.
Hit it with a rubber mallet.
You need to scare them.
Woo, Lord. Okay, gonorrhea. Unfortunately, gonorrhea is the most reported communicable disease in the United States, and apparently Rowan County has a high rate. 65,000 new cases every year in the United States of gonorrhea is reported. Scary, huh? All right, the problem with gonorrhea, well, first off, you have your onset 3 to 10 days after exposure. The problem with gonorrhea is that you often don't see the issue. Women have silent infections. Now, why would that be? Why is it not as obvious as this?
They don't understand inside their body.
Because our area is more hidden than a man's. So gonorrhea can affect women a little bit differently, but they do. This is the signs and symptoms of people who do have complaints: painful urination, dysuria, penile or vaginal discharge, which is what you see there. It is typically profuse yellow-green discharge, which you can't really tell the color there, but it's yellow-green. Not special. Anal itching. They will complain of anal itching if it is transmitted that way. Painful defecation. Now, there are some long-term effects. Prostate problems with men, it can cause prostate problems because it can spread to the prostate. And with females, if you don't treat it quick enough, it can cause PID or pelvic inflammatory disease. So it really needs to be treated as quickly as possible. Okay? And again, it can be treated. This is one of those, so far, the only one we've talked about that can't be cured is genital herpes. Okay? Gonorrhea and chlamydia can both be treated. They can both be, you get medicine, you get antibiotics for it, it's gone, we're good. Okay, so it needs to be treated. There are the medications that they treat with, and this is a baby with gonorrhea in her eyes, a newborn. Again, it can be transmitted during birth. That is why they put erythromycin in the eyes of every newborn who's born, whether or not the mother had an STD or not. Every newborn who is born gets the eye prophylaxis, which is the erythromycin ointment, and you all will probably give that, will probably participate in that, and you put it inside the eye. Okay?
Don't they test you for all this stuff though?
They do, but that's a one-time test. You could have been exposed
You
after the
should
fact.
say tested negative and then got it.
Yeah. Yeah. Okay. These are the drugs: Rocephin, Cipro, or Fluoxin, and they also give Zithromax. So it's one of those three plus Zithromax. So it's a combo thing. You always give Zithromax, and then you also give one of those other three.
What you said is in the eye?
It's erythromycin ointment. Okay. Now, sexual partners also need to be treated. This is again like your chlamydia. Well, all of them. You know, you report it, they're going to follow up. They're going to follow the chain so that everybody is treated. They don't require you to have a follow-up test after the medication is done, but it is encouraged to make sure that it's gone. So after you've done all your treatment, your antibiotics, and after you finish the course, it's nice to have a follow-up. You encourage them to have a follow-up appointment as well. All right, so what would we tell these people? We're going to teach them. Contagious?
Yeah.
Yep. Very contagious. You also teach them the importance of taking all their medication. How many people do you know that stop taking their antibiotics as soon as they start feeling better? Right? And then what do we have? We have these big bugs that are still around, these super bugs, because people have stopped taking their antibiotics and they've started to become resistant. So you make sure that they take all of their medication. How important that is. All right. Chlamydia. Find your chlamydia bug. Chlamydia. This one I found a picture of both for you. Yay. Okay. Chlamydia is the most commonly transmitted bacteria in the United States. We talked about gonorrhea, but it's the most reported. Chlamydia is the most commonly transmitted. Again, we have problems with women with chlamydia because of the area is not so visible as it is with men. And it does produce this discharge just like it does with gonorrhea. It does take a little bit longer for chlamydia to onset, 1 to 3 weeks, as opposed to your 3 to 10 days. And look how long it can last. A year in women, 5 months in men. Okay, so it can actually reside in the body a long time before symptoms start showing. In fact, they say that 70% of women who are tested for chlamydia are asymptomatic. They don't even have any symptoms, and they test positive. So that means that they've been exposed and the virus is in the system, they're just not showing any signs yet. So that's a long time. Okay? In men, they are going to complain of painful urination, urethritis, a painful urethra, of course dysuria, polyuria, frequent urination, and a watery discharge. It is not as thick, I was going to say less thick, that didn't sound right, not as thick as gonorrhea. The gonorrhea discharge is more thick and mucousy. This is more watery. That's how you tell the difference between chlamydia and gonorrhea. Women complain of the same type of thing, but you see again, women are 75% of them are asymptomatic. But when they do start showing symptoms, it's the same type of thing. Painful urination, frequency in urination, painful or tender cervix, painful sex. If it is not treated quickly, again, it can cause pelvic inflammatory disease, prostate issues. So they need to be treated. And again, this one is treated with an antibiotic. Okay. This one is treated with a double antibiotic. It's treated with your Zithromax and doxycycline. So the other one, we had 3 different ones, the Rocephin, the Floxin, and the, I can't remember the other one. The Rocephin is usually the one that's given, but Zithromax and doxycycline on this one. There is a complication of chlamydia called Reiter's syndrome. Reiter's syndrome is a connective tissue problem, a connective tissue disease. So also not only do we have the risk of PID and prostatitis, but you have the risk of this Reiter's disease. Connective tissue disorder. Connective tissue disorder. And so they're going to complain, with Reiter's disease, they complain of painful joints, painful swollen joints. They'll have a fever. Okay. And what's essentially happened is that the bacteria has settled into, again, the connective tissue. And where else do we have connective tissue? Everywhere, around the heart, the lungs, everywhere. So that inflammatory process can be a big problem. Okay. Teaching them basically the same thing. They are to avoid sex for 7 days from the start of the treatment. That's one big thing you always want them to wait to have sex until the treatment is over, especially though with chlamydia, and they need to wait a good 7 days before. And who else are we treating again? The partner. And very, very, very important, because if you don't treat the partner, of course, you're going to become reinfected, and nothing is going to, it's like a vicious circle. So being very honest, and you have to, some of these people, you just have to say, look, it's time for honesty here. Because if they don't, and then they're out there spreading it to everybody else. So, really, really important. Okay. We're almost done. We'll finish with STDs today, or big bad bugs. All right, look for genital warts. And you should have a little warty looking bug on there. The fancy name for genital warts is Condylomata acuminata. Big fancy term. There's a lot of press now about HPV, or human papillomavirus, because of what? Because it's causing cancer, cervical cancer. And so what have they done now to try to prevent this from occurring? The vaccine, the Gardasil vaccine. If I'm not mistaken, they're giving it to boys now too, right? Everybody's getting shot up, right? I think it's very important for you to get your teenagers in the shot, and do not tell yourself that they are not having sex, because they probably are. They are. Let us all remember ourselves as we were teenagers. Okay? Some of you may have been really good. Others of us probably weren't. This is the most common sexually transmitted viral disease in the United States. It is a virus. Duration is forever. It is not ever cured. It's kind of like your genital herpes, where it will come back in times of stress, pregnancy. The difference between genital warts and genital herpes is that genital warts are more wart-like lesions, as opposed to the blister-like lesions of genital herpes. So that's the difference between the two. It can be treated with creams. You can also take the warts off. This is a vagina.
Yeah.
Okay. There are different types of creams, as you see up there, and they work different ways. Podophylox and imiquimod cream, and podophyllin resin. Those are all different types. One of the things that you treat these patients with these medications is that they need to make sure to keep skin of the genital area clean and dry. Pedophile resin. It's thick like tree resin. Okay.
Oh.
One of the things that we really haven't mentioned with any of these, but it's very, very important for females, is to have regular pap smears, because pap smears is going to pick up on these disease processes. So it's very, very important to make sure that they have regular, yearly, annual pap smears. Some of these, if they have the presence of one of these STDs, it will cause an abnormal pap smear, and they'll have to go back in 6 months and have another repeat. And that's just so that they can make sure that none of this is settling in the cervix, causing the cervical cancer, or causing PID. So very important to make sure they understand that process.
Do they get this different treatment based on the severity of it, or do they get all three of them?
No, it just depends on the physician. Yeah. Which one they prefer using. All right, your last one is PID. Now, the reason that I put an umbrella up there is because PID is an actual umbrella term for different types of infection, okay? So you see all the different types. There's salpingitis, endometriosis, peritonitis, oophoриtis, perimetritis, and tubal abscess. What do those tell you? Where it's located, right? Where it's located. The most common site is the fallopian tubes. The most common site for PID is the fallopian tubes. Okay? And that would be your what? Salpingitis. Oophoриtis is your ovary. So that's the most common site for PID to settle. Now, the thing about PID is a lot of people associate it with STDs, that it can enter during intercourse. But PID can also be contracted through surgery or childbirth. So it is not necessarily, the reason that it's included in this section is because it can be during intercourse as an STD, but you can also develop PID through surgery or childbirth. So, don't always assume that it's because of an STD. PID is the leading cause of fertility in women. We talked infertility. We talked about infertility a minute ago. Women who have are infertile, the reason is from scarring from PID. And chlamydia is the most common cause of that scarring, causing infertility. So, okay. People who are most at risk are young people who are under the age of 20, people who have multiple sex partners, people who have IUDs or other STDs. Those people are most at risk for developing PID. So remember that PID is an umbrella term. So that under that umbrella is where the area the PID is. Now these people are sick. Very, very sick. Some of the sicker people I've seen. Very, very, very sick. They are hospitalized. These people are put in the hospital. and they are put on antibiotics for 14 days. So they are in the hospital for a very long time. And they're very sick. Did I mention that? They're sick. They need to be in the hospital because they also are in a lot of pain. The other slide before it was just on education. Yeah, more manifestations we'll talk about. Okay. Now, these people will complain of high fevers, really high fevers. They come in, they have 103, 104 temperature, vaginal discharge. They're going to have severe lower abdominal pain, so they're going to be given lots of pain medication, which is again why they're in the hospital. They will actually come in and they're hunched over. They don't want to stand up straight. We call it the hunched over gait because they are so much in pain that they don't want to stand upright. There is a procedure called a coldocentesis. And that tests for the organism that's causing it. A coldocentesis. Everybody see that? And a coldocentesis is where they actually will go in and aspirate fluid. They aspirate fluid from the uterine space, from the rectouterine space. And they test that fluid for the microorganism. So coldocentesis, they go in, they take the fluid, they aspirate the fluid, and they test it for the presence of whatever bacteria is causing it. And that's how they know what to treat it with, which antibiotic to treat it with.
Is that a surgery or is that done in the office or?
No, it'll be done at the hospital because they're in the hospital. It'll be done at the hospital. And they usually take just a big old needle up in there.
Is it done vaginally?
It's painful. But they're in so much pain already, they don't know about it. They don't care. Okay. Do you see what I got in big, bold, capital letters? Those F's. Of course, they don't really want it anyway because they are very, very, very sick. Okay? All right, tomorrow we are going to